Okay, well, welcome everyone to Concurrent session number 15, entitled Enabling Innovation Through Synthetic Data, an Alberta Case Study. My name is Janine Kaye. I work for the Canadian Institute for Health Information, who is a co-host of eHealth 2022. This session is a panel discussion format, so if you have any questions or comments for our panelists, please type them directly into the chat, and we'll address them as time allows at the end of the presentation. You're also encouraged to connect with the speakers after the session via the virtual event platform. So now I'd like to welcome to the virtual stage our panelists. We have Reg Joseph, who's a CEO for Health Cities, Dr. Dean Eurich, who's a professor at the School of Public Health at the University of Alberta, and Brian Hamilton, who's the president of BW Hamilton Consulting. So I'll pass the floor to Reg now, who's going to begin our panel.
Thank you very much, Janine. I'll run through very quickly here the agenda. We're going to go over why synthetic data, why do we think it's interesting, and what opportunities it can provide for us. We're going to do a deep dive into some work that's already been around synthetic data in terms of its generation, how we validated it, and some industry potential applications there. Of course, because we're dealing with health data, privacy and security is a key concern. So Brian will deal with that, and then we'll have an opportunity to talk about some next steps and some Q&A. Next slide, please. So one of the things that in terms of our session objectives, we really want to look at health data for decision making, and we know that this is going to be key to drive innovation in our health system. And this has been a long challenge, as many of our listeners will know, in terms of particularly for industry to get access to prove a certain solution, whether it works or not, and the impact it can have on the health system. Data is required for that, and quite often we have significant barriers related to access to data. What we want to do is to gain insight into the data validation for synthetic data. How well does it work? Where does it work? What are some use cases for it? And what are some limitations around synthetic data? And lastly, of course, as I mentioned previously, one of the key objectives will be to understand some of the privacy and security concerns and considerations. We've had a nice working group here in Alberta that's been helping us along with that, and we'll talk about some of those privacy and security considerations as we move forward. Next slide, please. So on the initiative, as many of you know, the business problem, I kind of alluded to it a little bit earlier. In Alberta particularly, we've been boasting the largest health authority in Canada, covering about 4.5 million people, with the associated data with it. But as you know, even though we boasted this opportunity and the power of the data that we have in Alberta, we really haven't been able to utilize it to the extent that we would like to, particularly from a sharing component. Always looking for opportunities to share with community, academia, and industry to drive better health decision making. So that's really our business problem that we're trying to solve. The opportunity here is synthetic data as a technique might offer us a safe and viable opportunity to share data. So we believe that because of the way synthetic data works, we're not actually de-identifying or anonymizing data. It's actually creating synthetic data sets that are not linked to individuals, that it offers us this opportunity to actually look at a sharing framework with health data. Next slide, please. So phase one, project objectives, what we're really looking at here is how did we establish the synthetic data set, and is that data set representative of the real data? We are also looking at privacy and security concerns, and creating a framework of how we share going forward. And then also doing a deep dive into analyzing and validating the synthetic data set, where does it really work? Where some of the opportunities lie, some of the use cases, and where some of the challenges lie, or where the use cases don't quite fit. In project two, once we've sort of validated that, and we'll talk about how we did validate that, now we want to do a bit of a real life example and prove utility from an industry perspective. So bringing in an industry partner and looking at actual use cases where we could apply synthetic data. Next slide. And I will pass this over to Dean.
Thanks, Reg. So I'll maybe go through the actual project and share with you probably what you're all here to listen about, the results. So we had a large number of partners on the project, as you can imagine, when we're dealing with health data, privacy, those types of things. So it involved obviously Healthy City and the Institute of Health Economics. Our industry partner who had a vested interest in trying to use some of this synthetic data as a case study on their end was Merck Frost of Canada. We had a number of partners at the university. Our synthetic data vendor was Replica Analytics, who helped us generate the synthetic data. And then obviously the key partners around health in the province and the privacy groups around OIPC, which is the Privacy Commissional Group, Alberta Innovates, Alberta Health Services, and other stakeholders as well. So it was a fairly large group that we were trying to manage through this. So we started this initial planning and idea way back in October 2020. As you can imagine, the pandemic did throw some curveballs around how we could progress with the study, but overall, we were able to move forward quite quickly. We generally had every couple of months touch points. We were hoping to have the synthetic data and approvals done, really within the first year or so. But that has taken a little bit longer, both in terms of some of the generation side, but also just making sure that all those pieces are checked in terms of meeting the requirements for both the providers of the original data, which is Alberta Health and Alberta Health Services, and then obviously the privacy piece. So the first project was really around just that conception model, could it be done? And then the second phase was, if it can be done, is it as a sufficient level and valid enough to be used by some of these external partners like Merck and others who may be interested in using this particular data set moving forward. So how did we go about this? So as I said, we had a number of different partners, specifically Alberta Health, Alberta Health Services, but also some of our funding institutes around the country as well. Obviously, I'm in the School of Public Health, which supports me, but we really wanted to look at whether or not synthetic data could simulate real world individualized patient level data by basically replicating a typical time to event study that is often done with health services type of research. So we had an exposure to a particular drug, and then we just basically followed these people up over time to see what the impact was in terms of overall mortality, ED visits, which is emergency department visits, or hospitalizations. And what we did is we ran the analysis in the real data, and then once we synthesized the synthetic data, we ran that exact same analysis. And the theory is that if the synthetic data is matching what's happening in the real world data, your point estimates, 95% confidence intervals, et cetera, should overlap quite substantially because you should be getting basically the same results in both data sets. So that was kind of the aim of the project to begin with. So in terms of data safeguards, as you can imagine, we are dealing with real world data from patients within Alberta. So there was a number of steps that are taken in place. Obviously, ethics had to be approved, but we also signed a number of data sharing agreements between the university and Replica Analytics, which was outside the university system to generate that synthetic data. We also had many discussions with Alberta Health and Alberta Health Services around what information could be released to Replica and how that data had to be released to them. Importantly, the data always stayed in my control at the university. It was always on encrypted servers with password protection, and Replica accessed the data through secured VPN type of connections with our university systems. So all in all, the data process was very secured from start to finish. So as I said, we used a typical analysis for administrative health data. This included a number of different data sets that we have available to us in Alberta. As Reg talked about, we do have one of the largest integrated database systems in the country. It's very well sought after, it's very complete. And so this included all drugs for all people, which comes out of the Alberta Netcare Pharmaceutical Information Network. So if any dispensation that leaves a pharmacy shows up in this data set, regardless of whether or not you have ability to pay for that drug or not, or who's paying for it. The ambulatory care system is our emergency department visits. Then we have inpatient claims, physician claims, a provincial registry, which monitors obviously patients moving in and out of the province, as well as all births and deaths within the province and demographics. And then, which is somewhat unique to Alberta, is that we do have laboratory data that can be linked in on all individuals who have completed any laboratory work in the community setting. So it's a fairly comprehensive list. As you can imagine, within any one of these data sets, there are literally hundreds of variables. And then within those variables, there's literally thousands, somewhere up to 10,000 different codes that could be used to identify that particular data field. And so the data itself is quite complex. So this is just a snapshot of looking at inpatient data. So we have identifiers of what institution, whether they were transferred from institutions, transferred to other institutions. We have 25 diagnostic fields that can be used by the coders in the hospital to say why you came into the hospital, what was your chief complaints, what care did you receive, what procedures did you receive. We have all kinds of coding around interventions, procedures, how long you're in the hospital, transfers, as I said. And so the data is quite complex. In the average health services research model, we tend not to use all of this particular data. We obviously tend to stream it back a little bit in terms of our main variables of interest. And so for this particular case, that's what we did as well. We didn't get them to replicate the entire, Alberta health system, but we did get them to try to replicate and synthesize kind of those key variables that we would be using in a typical health services research process. And again, this was guided a little bit by our end users as well. They obviously had vested interest in what variables they might be interested with. And so we tried to look at those as we move forward. But to give you just a sense of what we did, so the demographics, obviously we used all the demographics that are available on clients here within the province. Out of the drug files, we limited it to basically the amount to dispense, the drug, the DIN, and then a couple prototypical drugs that we were interested in for this particular analysis, which is around opioid use. So we limited the drug file, which has on any given year upwards of 40 million different line items of drugs that have been dispensed. And so we limited it to morphine, oxycodone, and a prototypical, another drug that's used in this population is very common are antidepressants, because there's a lot of depression associated with pain, those types of things. But the data set does have obviously every drug known to man in it, but we didn't replicate all those ones. Same with our visits for both the hospital admission, emergency department, as well as physician claims. We really tried to limit it down to the date that they came in, their chief or their second chief reason why they were seeing that clinician or had to come into the hospital. And then we included a marker of just how many services that individual received in terms of what we call the resource intensity weight, which is used by a number of different models for costing costs within the healthcare system. And in terms of labs, again, you can imagine there's tens of thousands of different labs that can be ordered on individuals in the community setting. We actually limited it to what we'll call kind of your prototypical labs that a normal person would get when they go for a routine follow-up with their clinician. So things around, your blood levels, blood cell lines, infections, those types of things, kidney function, liver function, were really the big ones that we limited it to. And again, we weren't trying to replicate the entire hospital and systems. We're really just trying to make a prototypical data set that would be suitable for most people at the end of the day. So that said, even though we've restricted it down, out of the 1,000 different variables that we might have in these data sets down to about 50 different variables, the complexity of the data is still immense. So you can have individuals in this particular data set that only had one particular claim. So they may have seen a physician on one day and that was it. And then on the other side of the coin, we had individuals that had up to 5,000 different events occurring throughout the time period. And so this was a 2-year study from 2018 to 2019. And so you can try to imagine that trying to model a patient's trajectory through a health system when you have 5,000 pieces of information to put in place is very complex. And so the idea around this was, it's not hard to generate synthetic data for an individual variable. I think everyone would agree it's fairly simple to do. But when you're talking about the longitudinal aspect of these data sets and trying to make sure that they're not using a heart failure medication before they were first diagnosed with heart failure, they obviously can't die after they or be hospitalized after they had a mortality event within the province. So there's a lot of things that have to be done correctly, and they have to be sequenced correctly in order to get the right trajectory of a patient within the health system. And I think that's really where the difficulty of this whole process lies, is that it is difficult, and the methods are still being developed to do that efficiently and properly, and to make sure that it is a validated data set at the end of the day. So out of our data set, it's shocking with this number, but we have about 2.5 million individuals a year who receive an opioid prescription in the province. So that's a massive amount of individuals. We weren't really interested in replicating all of them. This was just a test case. It's no different whether you're replicating 250 million people or 10 people. It's just compute time. The processes are all the same. And it's just how much time can your processors take to chew through all that data. So what we did is we randomly selected just 80,000 people. Just again, that number was just out of a whim. We thought it would be a good size to try to replicate, who had received an opioid between January 2016 and December 2017. And we're over 18 years of age, is what we've kind of restricted our data set to. Our primary outcome was the time from their first exposure to an opioid to either all-cause mortality, emergency department visits, or hospitalization. And then as a secondary outcome, we also included a very specific cause for hospitalization related to pneumonia. And we did this as just a prototypical example of a cause-specific endpoint that people might be interested in data sets. In terms of the methods, it was pretty standard t-test, those types of things. We use a Cox proportional hazard model to model the events. Because we're dealing with such a large data set, we didn't compare p-values specifically between the real and synthetic data, but instead what we did was we relied on the standardized mean differences, which really takes into account not only the estimate that you're getting from the data, but the variability around that estimate. It's a little easier to try to interpret than the p-values when you're dealing with such large sample sizes when we're doing those comparisons. As I said, it was a standards Cox model, so we basically followed those individuals from their first opioid dispensation until their event of interest. We did do a couple of multivariate analyses. Again, this is maybe a little more crude than what you'd expect within a peer-reviewed publication, but we included age, sex, a marker of comorbidity scores, which is called the Elix-Hauser comorbidity, which looks at all your physician visits, ER visits, and hospitalizations, and comes up with an overall score of how many chronic diseases do you have. We included antidepressants as a prototypical example of another drug that individuals are on. And then on the lab data, we used ALT, which is a marker of your liver function, EGFR, which is a marker of your kidney function, and hematocrit, which is one of the blood markers that is typically ordered on people in the province. So what did we find? So here is the synthetic data on the very first column, and then we have the real data, the p-values for the difference between those, and then what we call the standardized mean difference. And for us, the standardized mean difference was really our focus point. You'd like that to be less than 0.1, meaning the differences are fairly negligible between the two groups. So you can see with age, sex, and Elix-Hauser, fairly similar distributions between the two data sets. Average age is around 43, 50% were males, and around one chronic condition for most individuals. The lab data was a little bit more variable, I would say. Our liver function was fairly similar, but in terms of EGFR, hematocrit, from a statistical point of view, the standardized mean differences were a little bit high at around 0.3 and 0.2. Khaled and his team with Replica actually went back and redid some of this, and they got them down to that acceptable manner, but I'm just showing you kind of what the initial results were out of the box. Clinically, there's not much difference between them. So for instance, if you look at hematocrit there, HCT, you can see the mean was 0.41 in the synthetic, and the real data is 0.42. Statistically different, standardized mean difference is different, but clinically, there's absolutely no difference between these patient groups. So it's important to kind of keep in mind, some of that nuance of what is clinically important versus statistically significant for sure. In terms of our drugs, overall, about 4 to 2%, depending on which data set you looked at, were on opioid 1. Majority were on opioid 2, which was actually morphine in our particular data set. And then the other difference was really around antidepressant use. There was a little bit more within the synthetic data after they generated it compared to the real data. In terms of event rates, overall, they were fairly similar between the groups. The composite endpoint of any of those mortality or visits was around 90% in the synthetic data, around 85% in the real data. a little bit different, but again, I'm not sure how clinically important that is. Same with mortality, ED visits, and hospitalizations by themselves. And then at the end, we had the pneumonia-related, which was community-acquired pneumonia-related hospitalization, which was very rare in the data set, only happening in 166 people in the synthetic data and around 249 in the real data. So again, fairly close. The standardized mean differences were fairly acceptable levels for what we were looking at. So what did this data show? So here you have the different endpoints that we assessed in the Cox model. The top line represents the real data, and the line right below it represents the synthetic data. So you can see the point estimate, and then the little whiskers on the side are the 95% confidence intervals. So looking at mortality in the real data, we found morphine was associated with a significant reduction in mortality compared to oxycodone, and that's been well known in the literature, and we expected that relationship. It's obviously a confounded relationship, but that's the relationship we expected. The synthetic data was close, but not probably as close as we would like. It was around 0.44 in terms of its estimate. In terms of the rest of the estimates, so hospitalization, ER, and the combined endpoint, you can see the real and synthetic data overlap considerably, and there really was no statistical differences between what we observed in the real data compared to what we observed in the synthetic data. The pneumonia-related hospitalization was a little bit hard to evaluate just because there were so few events. The 95% confidence interval was so large that pretty much anything fit within that window. And so that was a little bit more difficult to look at. So the mortality estimate was a little bit different. One of the things you have to consider is that synthetic data is nothing more than just modeling the data in a highly sophisticated way, but it's still a model. And when you don't have a lot of event rates, the model has difficulty trying to predict what is going to happen. And so our mortality estimates, we had less than 5% of individuals having these endpoints compared to 80 to 90% having ER visits, hospitalizations, et cetera. And so what Khaled and Replica did is they went back to the drawing board and tried to tweak the models a little bit to be better attuned to these lower event rates within mortality. And we ran the model again, and so we got that down closer. So it went from 0.44 down to 0.35. And I can tell you they did another iteration and it got a little bit closer. So, with some work, you can get those models to work even for rare events such as mortality within the administrative health data. So that was kind of the opioid, whether it was our first foray into it. It was a pared down data set, as I talked about. We're actually doing a second project right now, which is a diabetes cohort study. It's much more complex, has far number more patients. It has 300,000 individuals, 1,000 variables included, and it's we're working on that in preliminary results so that the synthetic data is actually working quite well in that data set as well. So as I said, the complexity of the data set is generally not the issue. It just adds more compute time. And so these models take much longer to run, as you can probably imagine. And with that, that's all I have for results, and I'll hand it over to Brian.
And just to note, we've got about 5 minutes left in the session.
Hey, thanks very much, Dean. Yeah, so just to recap our first project from a privacy perspective, you can see that we created a synthetic data set and analyzed it under a research ethics board approval regime. So that means that we had a research agreement, agreements between all the parties involved, so our synthetic data vendor, the researcher, and as Dean said, the synthetic data itself, the original non-identifying data set, they all remained within Dean's secure controlled environment, and there was no further disclosure. So from a privacy perspective, pretty straightforward. In Alberta, when you operate under REB approval, you do not need to do a privacy impact assessment either. So relatively easy privacy compliance from that perspective. Now, what we want to do in project 2 is disclose synthetic data to a business partner, and that's where privacy concerns might be raised. So we'll talk a little bit about that. But the other thing that we also want to do with project 2 is create a repeatable methodology, the roadmap, or we're calling it a privacy pathfinder for future synthetic data initiatives. And we want to be able to do this both inside of a normal research ethics board approved framework, as well as for other purposes that might, just be data exploration, but not actually pure research. So the three big questions, that we look at with regards to synthetic data is, we want to make sure that the data controllers, so the custodians of health information, are legally able to disclose this information. One of the other, generally that's not too much of a concern within the research context, but how do we do that outside? Synthetic data, is it even non-identifying health information or personal information? It's as we've learned, it's data based on other data. It's a model. So is it even applicable under privacy law? If not, what frameworks do apply? One thing that's always important to note, though, is that the starting point for creation of synthetic data is actual real data. You have to base it on something. So there are always going to be some privacy and data security considerations at the starting point of creating synthetic data. And then we also are looking at, so if we have a custodian considering creation of the data, the synthetic data, is there a framework that they can use to analyze privacy considerations? So we'll go to the next slide. So we have proposed a privacy pathfinder. It's right here. You might think it looks a lot like a privacy impact assessment, and it does consider many of those same kinds of issues. We identify the data controllers. So where's the data source? They are the ones who ultimately have an interest in what is done with the synthetic data set. The purpose needs to be well defined. We look at legal authority agreements. Who's going to be the ultimate user of the synthetic data, and the where that synthetic data gets disclosed? Is it disclosed to the public, or is it disclosed in a controlled environment? These are all things that will impact the ultimate privacy analysis. And one thing we also want to be able to do here is make the public aware of what we're doing when we are using or disclosing synthetic data sets that are based on their data. So with limited time, I'll turn this back over to Reg to wrap up.
Yeah, thank you very much, Brian. Given where we are on time, I just thought maybe I'd see if there are any questions from our listeners at all. If not, I'll just give a very quick summary here. So one of the things that's happening in Alberta is that there is a Government of Alberta entire data strategy. So what's interesting is that the work that's been done by Dean and Brian here now is being looked at quite extensively, not only from the Ministry of Health, but also from other ministries to see whether synthetic data as a technique and a framework can work in many other areas where we have sensitive data. We're going to continue looking at testing assumptions for industry use cases and so forth. But more importantly, we actually like to use this from a talent perspective in terms of enabling our students in our academic institutions to work with health data and run AI algorithms and so forth on it. We're going to continue working with our data custodians on a framework on how can we use synthetic data and share that data in a sort of a protected environment. And then lastly, we also need to make sure that we communicate well to stakeholders in the community writ large as to what we're trying to do with synthetic data and what some of the opportunities are there, just to make sure that we've got folks here on side in terms of where we're trying to go with health data. So with that, I'll turn it back to the conference.
Great. We're right at 2 o'clock. So I wanted to thank all of our panelists for a really engaging discussion on innovation through synthetic data today. Next up, I'd like to invite all attendees to join our exhibitors for the networking discussions in our virtual trade show. You can access that at the top of your screen. And thanks for joining us today. See you all in the next session.